I want to welcome everyone to the Acute Oncology session. My name is Dr. Bilal Shehzad. I am the head of medicine at Shaukat Khanum, Lahore, and I'm a nephrologist by training. Chairing the session today will be Dr. Abid Jamil. He is an oncologist, and Dr. Fatehullah Khan. He is a pulmonologist at Shaukat Khanum, Peshawar. We have a very interesting session planned today. The talks address new challenges that arise from the use of novel therapies, as well as some innovative ways of dealing with some well-established oncological emergencies. Before I introduce the speakers, I want to go over the format of the session. The duration is 2 hours. We have 3 virtual talks. The question and answer session will be at the end. Please make sure you fill out the feedback form at the end so that you get your CME credit hours. The session is accredited to provide 2.25 hours. Okay. So without any further ado, let me introduce our first speaker, Dr. Mazin Khalid. He joins us all the way from New Jersey. He is an interventional cardiologist, and he works at Englewood Health. He will be talking about malignant pericardial tamponade.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. My name is Dr. Mazin Khalid. I would like to thank the organizing committee for the generous invitation to be part of this symposium, which to my understanding is the first of its kind in the region. And I hope, inshallah, that this will be the beginning of many more to come. I am a practicing physician in the United States. I've been trained in the US. I have various board certifications in internal medicine, cardiology, interventional cardiology, echocardiography, and nuclear cardiology. I will have the pleasure of speaking to you all today about malignant pericardial effusion. So pericardial effusion in general is a very broad topic. Out of respect to the time that I was assigned by the organizing committee, I'm going to try to make it brief, concise, to the point, and addresses the needs and the aspirations of the audience. So I have no disclosures, and with this, we're going to start by talking about the pericardium itself. Just a quick refresher. I know most of the audience are already aware of this, but the pericardium is fibroelastic sac, and it has the visceral layer and the parietal layer. In healthy individuals, it's normal to have some amount of pericardial fluid, usually about 15 to 50 mLs. And this amount of fluid is what we consider physiologic, that does not need intervention. Obviously, pericardial diseases are relatively common, and they can either present with pericardial effusion as the main presenting symptoms, or it can be a part of a bigger diagnosis or systemic disorder. The etiology of pericardial effusion is very broad. It includes infections, be it viral, bacterial, or fungi, radiation, post-cardiac injury, post-MI, post-traumatic, drugs and toxins. Metabolic is something we see commonly, especially with uremia or dialysis associated. And malignancies, obviously, are a common cause of pericardial effusion, collagen vascular disease, and idiopathic or immune-mediated. Obviously, as you can see in this slide, malignancy comes slightly low in the totem pole. That being said, because I'm talking to how is pericardial effusion classified? We're going to slice and dice, as you see. So it's either according to the onset, so we can say acute, subacute, or chronic. There are features in the echocardiography that can help the echocardiographer who's reading the echo identify, possibly identify, let's be more accurate, whether it's acute or subacute based on the presence of fibrin products or clots and so forth. Size, so we can classify it by size, which is mild, moderate, or large, which is, I think this is the most common way of classifying pericardial effusion. Another way in the description, we always say if it's circumferential or loculated. We see hemodynamic impact.
We seem to have a technical glitch. We will resume shortly once we fix it.
So usually we would say with or without echo evidence of tamponade. We never say.
Well, we're back online.
Okay. There is no tamponade because tamponade is a clinical diagnosis. I'm going to be hammering this point a lot in this presentation. So we always, when we read comment, if there is echo evidence of tamponade. Can differentiate it based on composition, but this usually is not an echocardiography diagnosis. This is an after the fact, after you do drainage and you analyze the fluid. Obviously, blood and pus can be seen before even the labs are out, but in general, we like to be more accurate with it. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. My name is Dr. Mazem Khalid. I would like to thank the organizing committee for the generous invitation to be part of this symposium, which to my understanding is the first of its kind in the region. And I hope, inshallah, that this will be the beginning of many more to come. I am a practicing physician in the United States. It has the visceral layer and the parietal layer. In healthy individuals, it's normal to have some amount of pericardial fluid, usually about 15 to 50 mLs. And this amount of fluid is what we consider physiologic, that does not need intervention. Obviously, pericardial diseases are relatively common and they can either present with pericardial effusion as the main presenting symptoms, or it can be a part of a bigger diagnosis or systemic disorder. The etiology of pericardial effusion is very broad. It includes infections, be it viral, bacterial, fungi, radiation, post-cardiac injury, post-MI, post-traumatic, drugs and toxins. Metabolic is something we see commonly, especially with uremia or dialysis associated. And malignancies, obviously, are a common cause of pericardial effusion, collagen vascular disease, and idiopathic or immune. Obviously, as you can see in this slide, malignancy comes slightly low in the totem pole. That being said, because I'm talking to an attendance of a cancer symposium, we're going to be focusing on the malignancy because malignancy overall is a complicated topic to tackle, and it's not uncommon that we see people with malignancy presenting with pericardial effusion either as a presenting symptom or at some point during their clinical course, and it behooves us to be able to recognize it because left untreated it can be fatal. So how is pericardial effusion classified? We're gonna slice and dice, as you see. So it's either according to the onset, so we can say acute, subacute, or chronic. There are features in the echocardiography that can help the echocardiographer who's reading the echo identify, possibly identify, let's be more accurate, whether it's acute or subacute based on the presence of fibrin products or clots and so forth. Size, so we can classify it by size, which is mild, moderate, or large, which is, I think this is the most common way of classifying pericardial effusion. Another way in the description, we always say if it's circumferential or loculated. We see hemodynamic impact. So usually we would say with or without echo evidence of tamponade. We never say there is or there is no tamponade because tamponade is a clinical diagnosis. I'm going to be hammering this point a lot in this presentation. So we always, when we read comment, if there is echo evidence of tamponade. We also can differentiate it based on composition, but this usually is not an echocardiography diagnosis. This is an after the fact, after you do drainage and you analyze the fluid. Obviously, blood and pus can be seen before even the labs are out, but in general, we like to be more accurate waiting for the lab analysis and so forth. Now, malignant pericardial effusion. I am not a firm believer of showing you graphs and trends. It can get boring and tedious after a while. I think it's better that I mention the articles that I looked at and then just give you the gist of it. So malignant involvement of pericardium has been detected in about 1 to 20% of cancer cases. Direct involvement of myocardium is much less frequent, and it's either metastasis or primary cardiac tumors. For the most part, tumors in the heart are usually secondary tumors. They're metastases, they're not primary. That being said, we do see primary cardiac tumors. In two large autopsy series, those are the two trials you see in front of you, the incidence of any cardiac involvement was 11 to 12% respectively. And of those, 76% had pericardial involvement and 34% had effusion. So you see that's a drastic number. 76% have some degree of pericardial effusions on as pericardial involvement on autopsies. And about a little more than a third had pericardial effusion. So the pathogenesis is very elusive, and obviously it depends on what we are talking about, because each and every cause of the 10 main causes that we spoke about have its own pathogenesis. Most pericardial disease in patients with known malignancies is due to malignant involvement. In several single center series of pericardiocentesis, the malignant etiology of pericardial disease was identified in up to 2/3 of patients. In the remainder of the patients, idiopathic pericarditis was most common, while prior radiation therapy contributed by about 10 to 20%. So the most common primary tumor involving the pericardium is lung cancer. I think this is very important, and I sort of underlined it, bolded it, and chose a different color just to help hammer it. Lung cancer is one of those cancers that is commonly associated with pericardial effusion. Approximately of 5% of patients with non-small cell lung cancer that harbors the anaplasmic lymphoma kinase rearrangement, in particular, those are more prone to having pericardial effusion. Obviously, you guys know more about ALK than I do as a cardiologist, but that's what the literature shows. Other common tumor types that are associated with pericardial effusion are obviously breast, esophageal cancer, melanomas, and lymphomas. Malignant tumors can involve pericardium by direct local invasion or through metastasis spread via the lymphatics or bloodstream. In addition, the primary tumor can arise from the pericardium, although they are much less frequent than secondary. Okay. Next, we're going to speak about other malignant-related mechanisms. So traditional chemotherapy, such as the agents mentioned and underlined, namely doxorubicin, cyclophosphamide, and cytarabine, have been associated with acute pericarditis and acute pericardial effusion. The statinib, which is a tyrosine kinase inhibitor that targets the PCR-ABL gene and the KIT gene, and platelet-derived growth factor receptor beta has also been linked to an increased incidence of pericardial effusion. Immune checkpoint inhibitors are increasingly being recognized recently to cause acute pericarditis, effusion, even tamponade. And data has been reported that shows some fatal myocarditis cases after even single dose treatment in combination of nivolumab and ipilimumab. Radiation therapy for the chest is also well known to be associated with acute pericarditis and possibly pericardial effusion, and even cause constrictive pericarditis. And that's one of the things we look at when we take history from patients. We always ask about history of malignancy, radiation, chemotherapy. Infectious etiology are not believed to be a common cause in cancer patients per se. Now, diagnosis of pericardial effusion, obviously, we always like to talk about echo, but we have to always remember our ABCs. So you always start with your history. You want to make sure you ask about the travel, recent illnesses, malignancy, what type of malignancy, chemotherapy, radiotherapy, when was the last dose, trauma, surgery, radiation, and autoimmune diseases. Signs and symptoms. So absent tamponade, physical signs and symptoms are neither sensitive nor specific, because if you don't have tamponade, you're not going to be able to tell. Yes, I can tell you you're going to have the stony dullness of percussion. I can tell you about distant heart sounds, but all of those are not sensitive or specific. They need experience. Obviously, the esteemed panel of faculty will be able to recognize it with their years of experience, but in a practical sense and manner, you can't say with certainty there is or there isn't pericardial effusion just by performing physical exam absent tamponade. you have to focus on identifying tamponade physiology, which is tachycardia, hypotension, and pulsus paradoxus. So those three are paramount. You have to be able to pick them up. Obviously, nowadays we do vitals on everybody. Tachycardia and hypotension should be readily available if you're looking for them. Pulsus paradoxus, though, you need to check it. You need to be vigilant. You need to make sure you measure the blood pressure. You ask the patient to take a deep breath and you watch that drop of systolic blood pressure of 20 or diastolic blood pressure drop of 10 millimeter mercury with inspiration. Every suspected patient should undergo EKG, chest radiography, be it X-ray or CT or MRI. We're going to talk about it in details, and echocardiography. Just X-rays may show cardiomegaly, but it's not sensitive or specific. ECG, so I put this into three portions. So low voltage. Low voltage is defined by less than 5 millimeters. 5 millimeters is one big square. You know how the EKG have small squares and big squares. So less than 5 millimeters in the limb leads. Your limb leads are lead 1, 2, 3, AVR, AVL, and AVF. Or less than 10 millimeters in the chest leads, which is V2 to V6. And even V1 is included to the party. We don't like to keep people in isolation. Presence of tachycardia and low voltage should raise your concern of PE. It should give you that sense that something is going on and I have to look deeper. Electrical alternus, which is also usually present with sinus tachycardia. This abnormality is characterized by cyclic beat to beat shifting in QRS. So if you look in the bottom of the screen, I don't know if you can see my mouse, but if you look at V3, you see one beat have high amplitude. The top to bottom is, if we counted 1, 2, 3, about 4 large squares. So that's about 20 millimeters. And the second beat have about 14 millimeters. So you see that there is a significant drop on the amplitude. This is because of the swinging of the heart. So you have, this indicates that the heart is sitting in a big pond of pericardial fluid and it's moving back and forth with systole and diastole. And when it comes closer to the chest wall, that's when you get that large amplitude QRS. And when it goes back, you get the small amplitude QRS. And that's why you get those alternates. One beat have higher amplitude, one beat have lower amplitude. Echocardiography, I put the pictures. I'm not gonna go into details. I don't know if there's cardiologists in the panel, but I'm sure if there is, they're well versed with it because that's one of the first things we are taught when we are looking at echocardiography and in training when we're dealing with it at night. But both specific and sensitive for the detection of pericardial effusion can also provide information regarding the hemodynamic significance. Again, I'm going to mention it. The pericardial effusion on its own is not a major problem at that point of time when you see the patient. It becomes a problem when there is physiologic effect of that effusion leading to tamponade physiology. It is important to obtain dedicated complete views to identify effusion hemodynamics. So, you know, when we're doing echoes, usually there are set number of views that we do. Obviously, if we're dealing with emergencies, we tend to choose the view that works with that emergency. That being said, pericardial effusion is one of those elusive problems that you do still. For example, if you have a loculated effusion, you're going to see it in certain views better than the others. You have to look at the IVC, the inferior vena cava, because that will have a significance that we're going to speak about in a second. So you can visualize a lot of information using the echo, the thickening